So, good day everyone. We are the group 3 and today we are going to tackle on the hemorrhagic shock. So, for today's discussion, we are going to cover the four main areas: the introduction, etiology, pathogenesis, and outcomes for us to understand more about hemorrhagic shock. So, what is hemorrhagic shock? The term hemorrhage describes blood loss, and shock is when the body is not getting enough blood flow or there is poor circulation of blood. Classically, there are categories of shock, and one of those is hypovolemic shock, where there is reduced blood volume. Thus, hemorrhagic shock is a form of hypovolemic shock in which significant loss of blood leads to inadequate oxygen delivery at the cellular level.
Etiology of hemorrhagic shock. There are numerous causes leading to hemorrhagic shock. Most common causes of it are blunt or penetrating trauma, followed by upper and lower gastrointestinal sources where bleeding may be external or internal. Since hemorrhagic shock is a hypovolemic shock from blood loss, the majority of potentially preventable deaths after traumatic injury are related to hemorrhage and occur early after injury, with the largest number of deaths occurring before hospital arrival. In penetrating trauma involves an object or surface piercing the skin, causing an open wound, examples of which are gunshot wounds, deep cuts, or stab wounds. Meanwhile, blunt trauma involves body injury through forceful impact, falls, or physical attack with a dull object, examples of which are physical assaults, car accidents, and falling from a greater height. And although trauma is the most common cause of hemorrhagic shock, causes can span multiple systems. Aside from trauma, other causes of hemorrhagic shock are gastrointestinal bleeding, bleeding from an ectopic pregnancy, bleeding from surgical intervention, or vaginal bleeding. Severe burns, amputation, or even severe vomiting and diarrhea can also lead to hemorrhagic shock if there is excessive or prolonged blood loss.
Pathogenesis. So now let's tackle the process that caused the etiology that was mentioned a while ago. So, due to injury or trauma such as blunt and penetrating trauma and other kinds of trauma, which was already mentioned from the etiology, so these traumas cause bleeding. And of course, when there is bleeding, there will be a blood loss. What happens next is that there will be a depletion of intravascular volume, which refers to the volume of blood in a patient's circulatory system. So, there will be a decrease in blood volume, and this could lead to insufficient oxygen supply. Ms. Rochelle?
So, hemorrhagic Thank you. So hemorrhagic shock is due to the depletion of intravascular volume through blood loss to the point of being unable to match the tissue's demand for oxygen. So this is where depletion of oxygen came. So blood carries oxygen along them. When heavy bleeding like in hemorrhagic shock occurs, these substances, the oxygen, are lost more quickly than replaced. There's not enough blood flow for the organs as time goes by. If this happens, as mentioned earlier, the body can't match the tissue's demand for oxygen since tissue needs oxygen to operate. As a result, the mitochondria, the energy-producing cells, can no longer be able to sustain aerobic metabolism. So aerobic metabolism uses the process of oxygen phosphorylation, but since there's not enough oxygen, instead, as a solution, it will switch to anaerobic metabolism to meet the cellular demand of adenosine triphosphate or ATP. So anaerobic metabolism still produces energy, but it does not require oxygen. So it was mentioned in our previous lesson, the glycolysis. So as a result of glycolysis, pyruvate is formed. So pyruvate is the product of glycolysis. So yun, pyruvate is produced and converted into lactic acid to regenerate nicotinamide adenine nucleotide or NAD+, to maintain some degree of cellular respiration and absence of oxygen. So that is how the body makes solution, an alternative solution for the depletion of oxygen.
So, if there is a blood loss or severe trauma happened in an organ or a damaged tissue, body reacts and compensate the blood loss by increasing heart rate and contractility. So, followed by the activation of the baroreceptor, which tends to send signals to the brain, and these signals are interpreted as a rise in blood pressure. So, the brain sends signals to the other parts of the body to reduce the blood pressure and to prevent the excessive bleeding to the damaged tissue. And because of the activation of the baroreceptor, this could also activate the sympathetic nervous system and the peripheral vasoconstriction. So, due to the activation of the sympathetic nervous system, the blood is diverted away from the non-critical organs and tissues or the unaffected organs to preserve blood supply to vital organs, such as heart and brain. But if this persists or prolonged, this could lead to deprivation of oxygen to other tissues, causing more production of lactic acids, which could result into worsening of acidosis. We know that acidosis can cause serious health problems. And this worsening of acidosis along with the hypoxemia, which is the low levels of oxygen in your blood, if left uncorrected, this could cause the loss of peripheral vasoconstriction, worsening of hemodynamic compromise, and death.
For the outcomes of hemorrhagic shock, it might be challenging to recognize the symptoms and signs of hemorrhagic shock, particularly if the bleeding came from an obscure source. Due to compensating mechanisms, the occurrence of hypotension is an insensitive indication until the blood volume loss reaches up to 30% of the total blood volume. Early post-traumatic hypotension is linked to the development of infectious complications and multiple organ failure. It may be easier to diagnose shock when non-specific clinical signs including anxiety, tachypnea, weak peripheral pulses, and mottled pale and chilly extremities are present. The American College of Surgeons Advanced Trauma Life Support Program categorizes hemorrhagic shock into 4 classifications. The following classifications are based on the projected blood loss in a 154-pound healthy person. First, people with class 1 shock have lost up to 15% of their total blood volume. People with class 2 shock have lost 15 to 30% of their total blood volume, while people with class 3 shock have lost 30 to 40% of their total blood volume. And lastly, people with class 4 shock have lost over 40% of their total blood volume. For a 70-kilogram male patient in class 1 shock, the only clinical symptom may be a mild form of anxiety. In class 2 hemorrhage, patients may look moderately anxious with a narrow pulse around 120 beats per minute, and the respiratory rate is increased and reached over 20 breaths per minute. In class 3 hemorrhage, the patient has tachycardia with a heart rate up to 140 beats per minute, while the blood pressure is reduced. The patient is also observed to be severely anxious, and the loss of consciousness may occur. Finally, class 4 patients are lethargic with severe hypotension and tachycardia, while the respiration rate is over 35 breaths per minute. The long-term outlook for people with hemorrhagic shock frequently results in mortality, kidney damage, and damage to other organs. In some cases, gangrene can also occur because of poor blood flow to the limbs. The damaged limbs may need to be amputated as a result of this infection. The prognosis will depend on the type of injury and the amount of blood loss. The prognosis is best in those who have not experienced significant blood loss and have no existing medical issues. So, when you begin to experience shock symptoms, you should seek medical attention right once to help you feel better overall.
So, clinical manifestations or signs and symptoms of hemorrhagic shock are as follows. Lips and fingernails. Bluish discoloration of the skin may signal a lack of oxygen in the blood. Cyanosis is the name for poor oxygen circulation in the blood that causes bluish discoloration of the skin. Central cyanosis affects the lips, but it can also affect the tongue and chest. Another is low or no urine output. Oliguria is the medical term for a decreased output of urine. Oliguria is considered to be a urinary output of less than 400 milliliters, which is a normal output of urine is 800 to 2000 milliliters per day. Infection or trauma, for example, urinary tract obstruction, are less typical causes of oliguria. These can cause the body to go into shock, which reduces the blood flow to your organs. Another symptom is shallow breathing. Signs and symptoms of hemorrhagic shock may not appear immediately. External hemorrhaging or bleeding will be visible. Internal hemorrhaging, however, may be hard to recognize until symptoms of shock appear. Signs and symptoms of internal hemorrhaging include abdominal pain, abdominal swelling, which can be caused by internal bleeding from trauma in the liver or spleen, blood in the stool, and blood in the urine.
So, another outcomes of hemorrhagic shock are abdomen or chest pain and potential bleeding sources. So, first is the abdomen or chest pain. So, there is a chance that you may experience a stomach or chest pain, and some of its neurological symptoms are disorientation, agitation, or lethargy or drowsiness that may also manifest themselves as a result of reduced blood supply to the brain. So the next one is the potential bleeding sources, which are like hematomesis, vaginal or abdominal or tunnel reason hemorrhage. So extremity bleeding is a readily apparent complication of trauma. However, its severity may be diminished in shock. So large volumes of blood may build in the proximal thigh and the retroperitoneal region, and this volume loss is easy to overlook until these areas are inspected. So the result is dependent on the severity of such disease when the therapy started and the amount of blood that was lost, the rate at which blood and fluids are restored, and the presence or absence of any further problems or complications.
So, in conclusion, shock can have a variety of causes, so it is critical to identify them as quickly as you can. A trauma surgeon, emergency department doctor, ICU nurses, general surgeon, internist, and intensivist work best as an interprofessional team to treat shock because it has high mortality and morbidity rate. With a better understanding of the pathophysiology of hemorrhagic shock, trauma treatment has evolved from a simple bulk transfusion approach to a more comprehensive management strategy of damage control resuscitation. The idea of damage control resuscitation focuses on permissive hypotension, hemostatic resuscitation, and bleeding control to appropriately treat the lethal triad of coagulopathy, acidosis, and hypothermia that occurs in trauma. Results vary depending on the underlying reasons, patient age, coexisting condition, and treatment response. Since the beginning of humanity, hemorrhage and hemorrhagic shock have been a problem. The pathology of shock has already been better understood thanks to the toxin hypothesis, but our progress in finding answers to the difficulties we currently face is still quite restricted. In comparison to its advancements in ensuring survival, technology improves more quickly when it comes to producing trauma, injuries, and fatalities. And that's the end of our discussion. Thank you for your time and attention.